Welcome, everybody, to Pediatric Grand Rounds. The voice you hear right now is Suzanne Mazer. I'm Director of Continuing Medical Education here at Seattle Children's. And with that, I will introduce our speaker for the day, Dr. Josh Weldon, who went to med school here in Seattle at University of Washington, did a pediatric residency also here in Seattle at University of Washington, after which he spent some time as a hospitalist both in town at Evergreen and also at Cadleck. He was away for about 7 years, and then he decided to return back to Seattle Children's to do his fellowship in pediatric cardiology. And then from there, he joined our faculty in 2015, and he's currently an assistant professor in pediatrics at UW and the director of the cardiology regional consultation program here at Seattle Children's. We're thrilled to have you with us, Dr. Weldon. Take it away. Thanks so much.
Thanks, Suzanne. And many thanks to Emily and Joe as well for their help. I'm at 70th and Sandpoint. The conference room here with the camera was being used for PALS, so my videos ended up looking a little bit like a hostage video anyhow. So I don't know. Enjoy the slides. So I'm gonna talk today about our regional program in the Heart Center, both in terms of the past and how we've taken care of patients and what we're doing currently, and maybe what the future could look like as well. So I appreciate you all logging in, and I totally understand if people are refreshing browser screens throughout this talk. Suzanne said she would interrupt if there are vote results that matter. So there you go. I have no financial conflicts of interest to disclose. So today we're going to talk about the history of cardiology in the region, talk a little bit about how and why things have changed over the years, and then talk about what we're doing currently in the region, and then maybe discuss a little more about future opportunities that we might have. And I'm going to try to shoot to leave 10 minutes or so at the end, because so many of us have done so much work in the region, not just in the Heart Center, and I'd like to hear other people's ideas and thoughts and learn from you guys. So hopefully we'll have some time at the end. So anyway, back to me. This is a little map of my journey that Suzanne outlined, and it's not the point to read my CV here, but I am very much a Washington State homer, having grown up here and gone to Garfield High School, done all my training in the University of Washington system, and then worked as a hospitalist at Evergreen, and then moved east down to the Tri-Cities, where I was the director of the hospitalist program at Cadleck, when Cadleck and Children's had an affiliation, and was involved in trying to grow and stabilize that program. And I really mention that only to say that before coming back, I think that experience was really invaluable for me and really cemented my interest in regional medicine, both in terms of really viscerally understanding what it is like to be far away from the large academic medical center, what it's like to have a sick kid and have people looking to you as the expert, even if you yourself may not always feel that way, and also learning to be really humble about what you know and what you don't know. It's easy to puff out your chest when you have the entire resources of Seattle Children's Hospital standing behind you, and so it was a really valuable experience for me. I also had in the world of cardiology, some great role models during my time there. The late Dr. Paul Herndon and Dr. Warren Taves were at the time doing outreach in Eastern Washington, and I really got to see what it was like for two experienced cardiologists to really lean into that work and make themselves very available, and just developed really nice relationships. Every Wednesday I would have dinner with them when they were in town, which I remember fondly. As I was reflecting on this talk, I was thinking a lot about what is regional cardiac care. And the more I thought about it, the more I recognized just how many people are really involved in this. This is not just the people who are in communities, but it's all of us here at Seattle Children's Hospital, right? This all works because we have amazing people and programs and clinical care at the hospital that we can hopefully provide and then return families to their communities. So it's nurses and medical assistants and our advanced, our APPs in the outpatient setting in cardiac surgery, our CICU APPs, our sonographers. I'm not going to read this whole list, but there's an incredible number of people, and I'm sure I forgot some, but you know, our guest services department who spend so much time with families when they're in Seattle, our care coordinators and discharge planners, and obviously our cardiologists, and I also put a plug in for our resident physicians who do a ton of discharge planning and help trying to get families back home. So I keep this in mind, and if I didn't list your role here, I apologize, but this really is a huge, huge undertaking that requires an enormous amount of coordination among so many people. Cardiology is really, regional cardiac care is really a continuum of care. And this was just a patient that I sort of made up, sort of based on a true patient, but thinking about families' journeys if they live far away from here in the Heart Center, I imagine, so this is a patient I imagine who lives in rural Alaska who had an abnormal screening ultrasound and went and saw one of our cardiologists in Alaska, Dr. Kevin Collins, pictured there on the far right. But this echocardiogram shows transposition of the great arteries where the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. And this would be a lesion that would be referred to Seattle to deliver here. Many of you attended Bob Naharia's fetal echocardiography talk a few years ago and learned a lot about fetal echocardiography. And then, so that family moves from their community to a strange place. They would deliver here, a picture of a cyanotic newborn, and then they're going to be transported to Seattle Children's Hospital. That ambulance is not in Seattle, but that is an ambulance in Southeast Alaska. It's very cool. Once they come here, they then need to have specialty care. So they have a balloon atrial septostomy and eventually an arterial switch operation with our cardiac surgeons. And then they're in the cardiac ICU. And then we are moving them to out of the ICU to the floor and working on discharge planning and feeding and teaching for the family. And in a case of a Native Alaskan family from rural Alaska, we actually now have a process where we send them back to ANMC in Alaska to do further discharge planning to their community, and then follow up would be, again, with our cardiologist, Dr. Collins there. And this is just one example, and every patient who we take care of in the region has a slightly different story. Some stories are just as simple as, you know, a patient I saw last week who was referred from our colleagues at Peace Health in Bellingham for a murmur. And they saw me and they had a physiologic murmur of childhood and they went home. They didn't come and have heart surgery, but they were able to have that care closer to home, and rather than missing an entire day of work and potentially income, they, you know, spent a few hours getting that medical care. So I think a lot about this continuum of care and all the people and work involved in this. So to do this care well, I think about the 3 A's a lot. So we have to have the ability to be the best heart center we can be in the United States and to provide really outstanding care and outcomes for our patients and families. And you guys have heard it a lot over the years from a number of my other heart center colleagues about this work, the amazing 3D modeling that Sujata Bude talked about, and the fetal program that Bob Nahari has talked about, and the single ventricle teamwork that Matt Files has talked about. All of these things coalesce into hopefully outstanding patient care, and it really starts with being really good clinicians and providing terrific clinical care, both here and in the region. The second A is availability. So availability in all sorts of ways, being available to our patients and families, being available to our colleagues in the region who don't have those hallway conversations. You know, I mean, some of the richest part of, and part of the reason why, frankly, I came back to Seattle Children's was I really missed those conversations where you could, you know, run into someone in the hall and say, hey, can I talk to you about this patient, or can you look at this echocardiogram? You know, we do this a lot in the Heart Center, and have really tried to make this the same for our colleagues throughout the region. So if you were in the echo lab today, the phone would ring a number of times both from people within our Seattle division or folks who would walk in to review imaging, but also, you know, I may call from up in Everett later, or Salam may call from the Tri-Cities later and you know, talk through some imaging with the echo lab. So that sort of work and availability is really important to build a regional program. We also need to really make sure we're communicating regularly about patient care and handing off our patients safely and thoroughly, both with our colleagues and as well as people who refer patients to us. The third A is affability, and in many ways, that's not just being sort of friendly, but also I think of it as being humble. So understanding that we who live in Seattle and primarily don't know the most about the communities that our patients live in, and so that means both reaching out to know our colleagues and the communities that they serve, and learning about them and being inquisitive, and also trusting their expertise about the communities that they live in. So sort of keep that in mind as we go through and talk about our services. So there's no way to give this talk without mentioning Dr. Stanley Stam, as well as Marlene Dana Miller, who's pictured with Dr. Stam here. So I think anyone who trained here and had the opportunity to get to know Dr. Stam and Marlene, and if you had the privilege of doing an outreach trip with them, really got to experience what those 3 A's we just talked about were, and how meaningful that was for so many people in the community. Dr. Stam started doing outreach in 1964 and continued to do outreach until he retired in around 2010. Also, perhaps most importantly, he was also a Garfield Bulldog. Dr. Stam's outreach trips took him many places, but took him to Alaska and Bellingham and Port Angeles and Yakima and Toppenish, the Farm Workers Clinic. And, you know, Dr. Stam did this work long before it was sort of, you know, not trendy, but it was really just a case of him seeing a need to care for families in our great big region, and did it with a lot of grace. And people in those communities very much still remember he and Marlene coming and how meaningful that was to them. And I was unfortunately unable to find as many pictures as I wanted of outreach trips, but I'm sure some of you listening got to go down to Boeing Field and Wings Aloft and have crab salad with Dr. Sam on outreach trips. If anyone has pictures of those outreach trips, please email them to me. I'd love to have them. But this was really a pretty amazing undertaking and really fun and meant a lot to families in those communities. Dr. Sam was by far not the only person who did outreach, and in the late 90s, 2000s, you know, Tom Jones and Troy went to Federal Way for many years, Troy Johnston, and Mark did a lot of outreach, and so did many other people. The late Paul Herndon is pictured there in the upper right. Many of you knew Paul, and Dr. Taves, who really stabilized our presence in Eastern Washington in the mid-2000s. But things look a lot different now, and so I want to talk a little bit about why it looks different, and then we'll talk about what our services look like now. So our state and region has grown enormously. This is just a graph of Washington state population from 1995 to 2020, but almost 18% rise in population. So there are more families in our state and region. The other states may not have grown as much, but the point being there are a lot more people here than there used to be. As a result, we've become a very big heart center. So we do about 600 surgeries a year. Our surgeons are pictured here. In the middle there is Dr. Dave Mockley, who recently joined us, and Dave has taken over the program at Mary Bridge in Tacoma, where we also operate. Dr. Mohammed Nuri, who's second from the left, unfortunately is leaving us. Apparently there's some sort of Good Children's Hospital in Philadelphia where Dr. Nuri is going to go work. So we're sorry to see him go, but excited to welcome Dr. Bahuta, who joins us via Great Ormond Street and the Ukraine. So we're excited to have Dr. Bahuta joining us soon. Our cardiac cath lab is incredibly busy as well. So between 800 and 900 cath procedures a year, and is nationally known for our interventional cardiology program. Our echo lab is incredibly busy, so we read about 18,000 echocardiograms a year with all these good-looking echocardiographers you see here, led by Dr. Luch Young on the far left. And a couple plugs for new folks. Dr. Lindsay Edwards has recently joined us. Dr. Matt Studer has also recently joined us after retiring from a long, successful career in the U.S. military. We're excited to have Matt, who's going to be doing a regional work. And then Dr. Elizabeth Karras at the lower right there has also joined us. In terms of ambulatory work, we do about 20,000 visits a year currently between main campus and the regional clinics, and I'll show a slide about the breakdown of that in a little bit. We also have a very busy transplant program, so all of our transplant docs pictured here. We do about between roughly 15 and north of 20 transplants a year. Those patients all come from all over the region. They have long-term complex needs moving forward, and this is just sort of a reminder of the type of work we're doing and why we can't just fly to Yakima once a month anymore. That's just not adequate to meet the needs of the types of patients we have. Pictured on the bottom row on the left there is Dr. Humera Ahmed, who recently joined the heart failure group as well. So we're excited to have Humera join us. In terms of that theme of complexity, this graph shows surgical cases reported to the STS database, which is the Society for Thoracic Surgery that all surgical programs report to. This is a scoring tool called the RACS score, which is an imperfect but somewhat useful score delineating surgical complexity. score goes from 1 to 6. Higher numbers are more complex, and examples of cases are listed below. So the most simple open heart surgeries are a RAC score of 1, like an ASD closure, up to the most complex surgeries like a Norwood aortic arch reconstruction in a single ventricle patient. And really what I would point out is that the trend over time is towards increasing complexity and more volume. So we have more patients who are more complex and more of them. Additionally, there's an important era effect to think about. So we care for a lot of patients who would not be alive 30 years ago. And those patients are often complex and have complex ongoing needs. That is certainly a theme in all of pediatric medicine currently, and is certainly true in the world of cardiology. This is a Kaplan-Meier curve from a data set from single ventricle patients in Texas. So the upper dotted line is a later era, and this era is the early 2000s compared to the mid-1990s. And the statistical significance here is relatively impressive. And this would only be more pronounced currently as we have more innovation and better patient outcomes. But I think it makes the point that there are more living patients with high complexity who are out in our region who need highly specialized care. This graph is another Kaplan-Meier curve that is sort of a reminder to me to make this point. We're also offering surgery to patients who in the past weren't always offered open heart surgery. So trisomy 13 and 18 who often have cardiac defects. Even when I was in medical school, my teaching and learning was that they were universally fatal and lethal, and these patients were generally sent home with comfort care only. And that's not our practice any longer. So we often have patients who are have comorbidities besides the heart defect that are now receiving care and surgery, but they're very complicated and need lots of resources and care coordination. This graph is a Kaplan-Meier curve, so it demonstrates that there is increased death rate in patients with comorbidities, but it's really a reminder to me to say that we are doing these surgeries, and in large part in previous eras, we weren't doing these surgeries. This is also just sort of my own thought about how Washington State has changed throughout my lifetime, from SeattleBubble.com, which is a highly reputable news source, but the graph is pretty interesting. So it's the median home price related to income over time for a roughly 25-year period. And you can see back when I graduated from college in the mid-1990s, the median home price in King County was around $250,000 and is well north of $500,000 at this point. And so the demographics of Washington have changed a lot, and people can't afford to live in Seattle any longer, and that means increased travel times and has had a huge impact on the demographics of the families we serve. The graph, or the table on the lower right there, is making the point that by one estimate, Seattle is the 5th highest cost of living in the United States last year, indexed for cost of living, which I think most of us understand viscerally. And obviously, this is just sort of a silly slide of a lot of traffic, but this means an enormous amount for people who are trying to get to Laurelhurst. Most people don't live in Laurelhurst, and most people can't afford to live in Laurelhurst. So providing this type of care really has a lens of equity for the families we serve, and how we can do that closer to home is really important. So as we think about these 1 million square miles here, how have we changed from that outreach model? We talked a little bit about the why, but what does that look like now? This is a pretty busy slide, and it feels like it's out of date every time we do it, and it is out of date currently, but all these dots represent places where we either have clinics or we have referring partners and folks we work with, and we'll kind of go through this. Some of the names are no longer accurate here. So in Alaska, both Danya Brecky and Jim Christensen are no longer there. Jim retired, and Danya moves back to the lower 48, and Kevin Collins and Corey Noel are there now. Also in Central Washington, Eddie Holtz has joined our group, and Veronica Schmer retired, and Steve Wendling we added in Montana. So we'll look at some of those slides here. So Alaska, it's pretty easy giving a talk like this to have a lot of pictures from Alaska, especially since Kevin emailed me a bunch of pictures, which I wish I could have shown them all, but I also wanted to include just the note Kevin wrote me when he sent pictures in my request. I'm in Fairbanks Clinic today, minus 22 this morning for me and Letty getting to clinic. I was just chatting with Jeff Banks, one of the local pediatricians here. He stood in line to vote this morning with a bunch of other people when it was minus 30. Go Alaska. And I really like that as I sort of thought about the 3 A's, right? Like Kevin is incredibly affable, and he's also interfacing with local pediatricians. And if we have a patient who's going back to Fairbanks, Kevin is the expert about providing care there. And I just think it sort of encompasses what, regional medicine is like, and the image of Kevin in his parka and Dr. Banks standing in line to vote in minus 30, I thought was pretty terrific. The picture in the top is a ambulance, a sled ambulance in a rural Native Alaskan village, and then a lovely sunrise in Alaska. A bunch more pictures here. The Alaska team has been very involved in the community, and this is a community event with a very cool beanbag toss, although I do personally have some competition with them, and I'll show a slide about that in a minute. That's what doing outreach in Alaska looks like. So, for me, I'm gonna, after this talk, drive north on I-5 to our clinic in Everett. And for Kevin and Corey, they're going to get on tiny little planes and fly all over a huge geographic area. That's the requisite picture of moose and dog sledding in Alaska, but those moose and those moose calves are outside of the clinic in Anchorage, so we don't deal with that here in North Seattle too often. That's Kevin and his sweet family watching the Iditarod. So this Kevin and Corey, and this is where their travels take them. They're based in Anchorage, but they're in Wasilla and Soldotna, and up to Barrow and Nome and Bethel and Kodiak and Juneau and Sitka and Ketchikan. So they're really doing amazing work up there, and have been terrific additions to our group. I would point out, as many folks know, that Ketchikan is actually closer to Seattle than it is to Anchorage. And so sometimes we'll see patients who get referred to Seattle for things like murmur evaluations. So sometimes we're seeing patients from Southeast Alaska and Seattle because it's actually geographically closer to Seattle than Anchorage. Our Eastern Washington cardiology group consists of 3 cardiologists currently, Dr. Eddie Holtz, who primarily is in Yakima, and Dr. Salam Salam and Dr. Lou Tony, who are based in the Tri-Cities, but also cover Yakima and Wenatchee and Walla Walla, and are all terrific colleagues who we work with a lot daily. These are so Children's Village, as many of you have been to as trainees and as specialists, in Yakima is where Eddie sees patients. And then the Tri-Cities Clinic is moving to a new space in Kennewick next year, which will be much bigger. So that's an exciting development. Excuse me. And then Wenatchee is near Confluence Health. Is our smallest clinic, but having gone there a number of times, I really enjoy seeing patients there. Denny Ruggieri joined our group a number of years ago, and Denny is based in Great Falls, and then Steve Wendling joined Denny last year. So there's Denny and Steve in Montana, and now you don't have to imagine a pediatric cardiology clinic with taxidermy. You can see photos of one here. So this is Denny and the crew at Halloween. Denny is Pac-Man. They are the ghosts, and a lot of stuffed animals. Not like stuffies, but like, you know, animals who are stuffed. But it is definitely, you know, just kind of a reminder of, again, like this is a clinic that fits the community that it's in, and just a reminder to me about that. Our South Sound Cardiology group, Don Triple, Sue Stevenson, Sudie Powers, and Josiah Penalver, they cover a huge, important part of the Pacific Northwest in the South Sound, and are currently our only outreach clinic in Silverdale to the peninsula, which is incredibly valuable for our families who live there, who don't then have to get on a ferry or drive around. And lest you think they're not a bunch of wild and crazy kids, here they are at Halloween last year, is Toy Story. So Don is Buzz Lightyear, and Josiah is the Green Army Man. You can imagine Josiah was the winner of the costume contest. Our 3 Western Washington regional clinics are in Everett, Bellevue, and Federal Way. Many of you on this call work there in other capacities and are colleagues there. I'm the medical director of our North Clinic, which is just north of the Prov Everett main campus and opened 2 years ago. As you may probably all also know, I am the North Clinic Chili champion, which has been covered widely in the news. And this was our beanbag toss game that is sitting on my front porch if anyone wants to borrow it. But this little girl was terrific and closed the ASD, the large ASD there, as you can all appreciate. But we're there 5 days a week in the North Clinic with 7 provider days, and really meaningful for our North Sound patients. Our Bellevue Clinic is our most mature regional clinic in Western Washington, and we're also there nearly every day of the week and do fetal studies as we also do in the North Clinic. And then the South Sound group covers our Federal Way Clinic currently, and are there multiple days a week for our South Sound patients in Federal Way. And if you want to know where it's at in the Heart Center, it's at least for ambulatory visits, it is in the region. So this is a graph of visits by site. So the blue bars are the main campus, and the green bars are all of our regional clinics. So we have followed a pretty clear trend where we're now seeing twice as many patients in the region as we are in Laurelhurst. And that, you know, I don't know if this will continue quite as dramatically in the next 5 years, but this sort of speaks, I think, to what's happening with our population demographics and how much people value and like and appreciate being able to be seen close to home. The regional consult service is a service that Meg Vernon and I have done together for the last many years. And primarily we support our NICU colleagues in Everett, at Evergreen, Overlake to some extent, and the University of Washington NICU in an effort to identify babies with congenital heart disease or arrhythmias who may need some input from cardiologists, but don't necessarily need to be transferred to Seattle Children's. And Matt Studer, who I mentioned, is going to help support some of that work. And Matt will also be doing a bunch of work at Valley and Renton as well, in terms of fetals and potentially supporting the NICU there. So this is another way that we're able to hopefully keep babies with their parents closer to where they live, and also, frankly, to decompress our own ICUs a little bit by not bringing every baby who doesn't have to be here. The amount of tele-echocardiography we do is pretty staggering. So we read echocardiograms from all of these different places. And so echoes come into the echo lab and are read by our echo docs, and often new congenital heart disease or other important clinical issues are identified this way. There's been a lot of work by a number of people in the Heart Center, Amy Schultz and Joel Lester in the past, and Artsy Bott, in terms of education for sonographers in these regional sites. So this isn't just the reading of echoes, but it's trying to help sites that don't primarily do pediatric echocardiography learn how to do pediatric echocardiography. This is a slide from Bhavna Arya's Grand Rounds from a few years ago, but this is just sort of my reminder to plug the fetal program. The fetal program is based at Springbrook near the main campus, but there's a lot of fetal echocardiography that goes on with folks in the region. So this slide is our own internal data, but 700 regional fetal echoes performed. About 7% of those referred to the prenatal center, and then about half of those who needed to have surgery or an intervention. And then patients who were seen in the prenatal center and sent back to the community to be followed by our regional cardiologist with a relatively low rate of fetal intervention. And then none of those patients who were cleared in the region needed fetal cardiac intervention. So a big part of our regional cardiologists are doing screening fetal echoes and referring them as appropriate, and doing so really successfully. While we certainly think a lot about the aspects of our regional program that exist out in the community, there's also lots of innovation in terms of getting patients here who need to be, and I think lots of people have heard about our mobile ECMO program with Mike and Rob Mazer, also known as Suzanne's husband, as I like to refer to him as, and Tom Brogan, and some pictures of what it is like to transport patients on ECMO in fixed-wing aircrafts and ambulances, and just recognizing that regional cardiac care is both low-tech general cardiology sometimes and the highest tech, most incredible cases and stories you can imagine. And then I'd be remiss if I didn't mention all of our colleagues who refer patients to us, and we refer back to them. So the Western Washington MEDNAX group, our colleagues at Madigan Army Medical Center. Dr. Studer's name is crossed off there because we done stole him away, but Kirk Weissmer and Ron Wells are still there. The Spokane group, who we share care of many patients of in Eastern Washington, and then patients from Boise, Idaho, who often come here for surgery and go back to see their cardiologist there, as well as the 3 other pediatric cardiologists in Montana, in Kalispell, Missoula, and Billings, as well as the other cardiology group in Anchorage, and a number of our colleagues in Hawaii, where we have had patients referred to us. So what does it take to pull all this off? Most of you know Mark Lewin. Most of you don't know that he was a professional wrestler, but Google is a powerful tool. He's slimmed down a bit and spent time here. He is in Anchorage at the I think the American Heart Association run with Kevin. But Mark has really been central, from my mind, in being very intentional about how we have grown our services in the Heart Center, recruiting the right people to do this work who have those 3 A's that we talked about, and making sure that we really keep this central to our mission and supporting it with the right people. These are some of those people. This is not an exhaustive list. Many of you know Emily Moore, who is one of our nurse practitioners, who's a clinician in the Heart Center. Emily also has had a regional role in the Heart Center for a long time, which she's still doing some oversight of. She recently was named as the Seattle Children's Manager of Advanced Practice Provider Education. And so Emily has really done terrific work for the Heart Center and for the hospital for a long time. Emily's background is that she is Alaskan Native. She's from the Tlingit tribe, and she gave me permission to show the slide. So if anyone knows Emily, they might think I would be in fear of showing a slide of her from 8th grade, but I had permission. But this is her in a traditional Tlingit robe and a drum that her grandfather made. And then that was the only other picture she would allow me to show of her with a mask on currently. I also we couldn't do this work without the efforts of Joni Blanchard, who's our Heart Center co-director, Andrew Lowe, who's our business manager, Kim Montgomery, who is our cardiac ambulatory and diagnostic services director, and Dan Hogan, who's our ambulatory nurse manager. There is a lot of work that goes into trying to both let folks far away be autonomous and be innovative and do things their own way, but also to provide standards. And a lot of work and intention has gone into that. And all of these people provide a great deal of, spend a lot of time traveling, at least prior to 2020, doing this work and building those relationships. Like, so much of this work is relational, and a lot of work has gone into this. And then Anya, who many of you know, is our Heart Center community liaison, and Anya interfaces with lots of our referring providers as well as with our families before they come to the Heart Center. Anya spends a lot of time educating families before they come to Children's and after they come, and spends a lot of time in the communities, and sent me some really great slides. This is just a slide to remind me that we are constantly trying to improve and making sure that we're communicating with our referring providers adequately. This is just a survey I sent out to folks who refer patients to us, and this is completely ongoing, continuous process improvement work. We always have to strive to do better, and Jessica Collier, who's our new inpatient director, is spending time doing work on how we communicate with our referring providers, and honestly to ourselves within the Heart Center. This kind of work requires that sort of ongoing efforts. Big plug for Arti Bhatt and Ken Rudberg. Ken and Arti collaborate on a lot of our quality improvement work, of course, within all aspects of the Heart Center, but also regionally. And Artie's done a lot of work regarding our FES scores in some targeted areas, as well as the strong QI structure that Luke Young and the Echo Lab does throughout the region, and a robust fetal QI structure. The purpose of this slide is not to read this 3-page Word document, but this is a back transport policy for our Native Alaskan patients that Emily made a number of years ago. And it's really detailed, it's complicated, but we identified sort of in that lens of being culturally humble that we were trying to send patients often back to communities that we didn't really understand. And so we now have a process to back transport Native Alaskan patients who live in rural areas to ANMC first, and then let their transition back to their community happen via the expertise of ANMC. Anya sent me some slides from Kivalina, Alaska, where we have a number of patients, but I'd sort of ask people as they think about that discharge process to think about what it might be like for patients who live in Kivalina. This is a picture of Kivalina, the grocery store in Kivalina, a loaf of bread that costs over $9, and what it might be like to travel to Kivalina on that airplane if you had a baby who had a feeding pump and oxygen and those sorts of things. Doing this work is a good reminder to us about what is involved in the care of these patients, and really deferring to the expertise of the people who live and know these communities best. I'd like to thank Renata Taylor from the Center for Diversity and Health Equity, who reached out to me and wanted to remind me some of the work that Guest Services does, and the CDHE for our Indigenous patients. In the interest of time, I'll let people look through this more afterwards, but just reminders about culturally appropriate care for various diverse communities. This is specific to Indigenous communities. And then there's a link here about the CDHE and how to request services. This is not Heart Center specific in any way, so this is true for many specialties, and I'm sure many of you have worked with them, but we really rely on the expertise of people like Anya and Renata and the CDHE to really help provide support for families when they're far from home. So what's next in the future? So I think, to my mind, the questions are, how can we grow our existing relationships to provide enhanced services? Are there things we've learned about our technologic ability to connect like this that maybe provide us some lessons? So can we be more present? And I think meaningfully present using technology in ways that we haven't been before. So thinking about maybe like rounding in the NICU as a cardiologist in our regional sites. So babies who might need, daily input from a cardiologist, could we leverage technology to do that sort of thing, and also help decompress beds here? And thinking about what communities could we serve better? As we continue to grow, I think there'll be a continued demand for subspecialty support. So are we going to be doing outreach cardiac transplant clinics? Are we going to be doing outreach EP clinics, cardiogenetics? Are we going to expand our fetal services? There's all these service areas that people would clamor for services for, and can we meet those needs? Lots of question marks and few answers, but I think these will be our continued challenges over the next few years. I will wrap up there and look forward to hearing any questions or thoughts or comments people have. That's my dog, Stanley.
Thank you so much. This is Suzanne. If you have any questions, feel free to type them in the chat, and then you can unmute if you want to have a conversation with Dr. Weldon. We have about 5 minutes for this. While I'm waiting for people to put their questions in, I'll just say thank you so much for being here, everyone, and especially to you, Dr. Weldon. I know we couldn't laugh as loud as you would want us to in real life. So just know that we are all laughing on mute, and we really appreciate everything you do for the region. You have some compliments coming in. Bravo from Emily
Oh, yeah.
Moore. And great pictures, by the way. Rob will be proud that he was included in Grand Rounds today. I took a screenshot for him.
Suzanne's husband.
Yeah. Right. Dr. Mr. Mazer sometimes.
That's right.
Hi, Josh. This is Jonathan.
Hey, Jonathan, how are you?
I'm good. I'm good. Great talk. Thank you so much, and congrats on the Chile champion title that you're holding right now.
Oh, I'm sure you've heard about it before, but yeah, thanks.
It's all over the region. But I had a quick question for you. As I just sort of looked at all the great work that's happening in the community in cardiology, I was curious, given the common interest in how to make cardiac care available in communities that may otherwise have limited access, and the common interest in that between, let's say, rural cardiac health and global cardiac health, whether any conversations have been had or could possibly be planned with people working in that space to sort of learn from each other about, potential best practices.
Yeah, that's a really good question. Obviously, folks who work in global health in the developing world have a wealth of experience with technologies like handheld echo and
Right.
training folks to do screening echocardiography in resource limited settings. And I think there's a lot of interesting areas there where, somewhat we probably struggle a little bit with standards of care in the United States, and some things that happen in the developing world that may not always meet those standards of care, but I think there's lots of interesting opportunities there. And certainly, I mean, obviously, you think about how healthcare is provided in Alaska with non-physician and
Right.
non-EP folks, right? So, is there an opportunity to leverage some of those trainings? That's a great idea and great question, and I think something that we would do well to think about and collaborate with those folks who do that work.
All right. Well, thank you everyone again for being here. We have some more comments for you. Great review of the history and looking into the future. Everyone agrees that they're definitely laughing on mute. And thanks for this great overview of regional cardiac services, Josh. So again, we really appreciate everyone's time. Thanks so much for being here, Dr. Weldon. We'll see you around the hospital and the region, and we'll see everybody next week. Thanks again. Have a good Thursday.
Everyone, take care.
Okay,
Bye-bye.
Bye.